Good morning, good evening, everybody. Welcome to a new webinar of the NEMUS series. We're pleased to start today a new phase of the NEMUS webinar series, this time as part of the knowledge sharing efforts of the PrEP project. And PrEP is a demonstration project on PrEP implementation in public health facilities in Brazil, Mexico, and Peru, supported by UNITAID, of which we will be talking in a session to come in the next few weeks. We promise to present on the project because we feel it's going to be useful for the purpose of NEMUS itself. In any event, as we know, global endeavors to ensure a better awareness of the opportunities offered by PrEP to strengthen HIV prevention are finally moving forward. And the International HIV Conferences have traditionally offered snapshots of both scientific debates, including related opportunities in the pipeline and implementation progress. As the recent conference in Paris, the IAS Conference, offers a good example of that trend, this time around we will be honored to host Dr. Omar Sued, Director of Research at the Fundación Huesped in Buenos Aires, Argentina, presenting on key contributions of the 2017 IAS Conference to the global PrEP efforts.
Omar is a specialist in internal medicine and infectious diseases. He's a master in comprehensive management of HIV and AIDS and a doctor of medicine from the University of Barcelona. He has been working in various fields in HIV care since 1997. From 2009 to 2012, he was a regional advisor on HIV treatment for PAHO, where he helped in updating antiretroviral treatment guidance for more than 18 countries. Since 2012, he's director of research at Huésped Foundation in Argentina. He was the president of the 16th National Congress on Infectology in Argentina, and is currently its secretary. The secretary of the Argentinian Society of Infectology. Anyway, we'll have a presentation by Omar. Today, he as you all know, he speaks Spanish, and he's kindly enough to present his same presentation in Spanish tomorrow at the same time. Now we're having him in English for a global audience, and so I stop here, and I will, Omar has the floor. The only thing is, if people have any questions or comments, please use the chat window, and at the end of his presentation, we can focus on questions or comments. So thanks a lot, Omar, and please start your presentation.
Okay, thank you, Carlos, for the invitation, and the NEMUS team for putting this conference on webinar. As Carlos said, I am Spanish speaker, so please, if anybody speaks Spanish here or understands Spanish, join tomorrow, because it will be better for you and for me. I will try to do the best. Sorry for my English and for my accent. I will try to share with you the best I can, and if I cannot do it well, you can ask for chat wherever you didn't understand. My conflict of interest, I participated in HPTN-03 trial. And for a start, as a small introduction, we should say that we continue using the traditional preventive tool that we have for HIV prevention, because these tools have a demonstrated efficacy and were being used for many years. But we can say that in the last year we see a revolution of the prevention, in particular through the introduction of treatment as prevention that changed the way that the patient relation with the partners, the possibility of self-testing, and the efficacy of PrEP. And we need to move forward and think in the future how we will prevent also the STIs and to diagnose and treat. But then the objective of this presentation is try to review the PrEP information that we got from the IAS conference, and we can see here the number of posters that PrEP really took a lot of place of the room in the conference, with 183 abstracts and posters accepted. And it's a reality in many countries. It's a reality, the marketing campaign for increase the demand also in many countries, as we will start to see in the few months in many cities in Latin America also. Many people are interested in PrEP because we know that can avoid new HIV infection, is cost-effective, improve quality of care, the people want, and is feasible. But many people also have some concern, and among those also some civil society representatives in my country, for example, are very cautious about promoting PrEP because the risk of complication, adverse event, resistance, or price. But nobody can deny the strong evidence that we have from more than 10 randomized trials with more than 10,000 participants receiving PrEP. In those trials that where people was adherent, the efficacy of PrEP was more than 90%. And so it's an intervention where we need to try to find the place in Latin America in all the comprehensive toolbox of preventive measures. What we learn in IAS about PrEP efficacy. I will share two studies or more information about two already published studies that are the PROUD, that presented the long-term follow-up in IAS, and the IPERGAY that presented the efficacy among MCM that had infrequent sex encounters. The PROUD is one of the most interested clinical design in PrEP. In this study, HIV negative patients, more or less 500 participants, were offered risk reduction strategies and Truvada immediately, or only risk reduction and then adding Truvada after 1 year of follow-up. And the participants were followed every 3 months, and the endpoint was to see the number of infections during the first 12 months. This trial was stopped early because the high effectiveness that was in the immediate group. There were, in the first 9 months, 3 infections versus 20 infections in the group that only was doing behavioral intervention. It's true that in people with immediate PrEP access was seen a more non-condom anal activity. It is true, but there was no big difference between the incidence of sexually transmitted infection. But this presentation was about what happened in the long term. As you see in this slide, in gray, the enrollment period in the first year of the trial was followed by the deferred phase that was stopped earlier in the blue arrow, and therefore all the participants started PrEP. And so this is called the post-deferred phase. During the 3 years of the trial, the proportion of people collecting PrEP was maintained more or less with a slow decline, and after 3 years, more than 60% of the participants were already taking PrEP. But the incidence, as you can see here, in the deferred arm during the first year was 9% people year, and this is compared with 0.3 in the post-deferred phase. So it's a more than 90% of efficacy. We see the incidence of STI was stable, was not reduced, in the patient and was more or less 35% patient years. And that means that the participants were really engaged in sexual risky behaviors. In conclusion, the PROUD trial showed that after 3 years, more than 60% of participants were still collecting the PrEP, that the high rate of bacterial STI confirmed that they really need PrEP, and the reduction of incidence was sustained. The second study, that's a Zippergate trial, is another beautiful study, was presented in 2015. This design in this case is with a placebo arm. MCM patient, 400 MCM patients were randomized to Truvada or placebo. And then in November, this study also was stopped early because the good results in the Truvada arm, and was the DSMB required that everybody go to Truvada. The innovative of this trial is that the posology of the Truvada was different and was 2 tablets before sex, 1 tablet during sexual activity, and the next day follow-up. And if the patient continue having sexual relationship, continue taking only 1 pill until 2 days after the last sexual intercourse. As you see in this slide, the incidence during the double-blind phase was 0.9 compared with 6.6 in the placebo arm. This means a reduction of 86%. But in the open label, the reduction was 97%. Only 1 infection that was thought to be when the patient that was not adherent. But the caveat for this study, and everybody said that maybe this study is not representative of the intermittent dosing, because many participants took a lot of pills because they had 10 sexual intercourse per month. So the median number of pills that they took was 15. So practically most of the patients were receiving Truvada 3 or 4 days a week, and everybody knows that with at least 4 pills a week, the efficacy can be good. So this presentation was to try to explore what happened in those MCM people that only have a sporadic relationship when they took PrEP or not, if these 4 pills were enough or not. And for this, the investigator used the periods on which the patient reported less sexual activity and adequate taking of PrEP. And then they summarized all these periods and could identify those patients that seroconverted right away the period in which they were taking few pills, and constructed this other graphic where they could trace and identify 6 infections along 134 person years of follow-up. But when we see at which arm belong each one, we can see that in all the 6 infections were in the placebo arm, and in the Truvada arm there was not seroconversion, in spite of taking only 9 pills and having 5 sexual intercourse. Therefore, this trial supports the evidence that infrequent sexual intercourse and people that have infrequent sexual intercourse and use PrEP, the PrEP continue being effective to avoid HIV. Regarding to new drugs that can be used, the most attractive probably are the long-acting formulation. And for long-acting, we have rilpivirine and cabotegravir. It was presented the phase 1 assessment of rilpivirine, and they show a small trial with 12 participants, 8 female, 4 male. The participant received 1 dose of one high dose of rilpivirine or a low dose, or 3 high dose at baseline, 2 months and 4 months. As in the demographic, there were no difference between female and male. There were no related grade 3 or 4 adverse events. There was a number of injection site reaction, but was not severe in any case. And the result of the plasma pharmacokinetics showed something that was seen before, that the rilpivirine tends to be different, the distribution among male and female, with higher pica levels among women than among men, and also that there is an accumulation of the drug after each injection. This issue and the issue that the inhibition in the cervix explant was lower than the rectal tissue, and also that the clade C was better suppressed than the clade B, and most of the infection in developed countries clade B, made that this drug was stopped as a PrEP candidate and will not continue being developed by the sponsor. The other drug, or the preferred drug for exploring a long-acting now, is cabotegravir. Cabotegravir is a new integrase inhibitor that has a oral formulation and also a nanomolecular formulation that can have level for 2 or 3 months. In the previous ECLAIR study, and a small study only in male, suggested that 800 milligrams every 3 months was not enough to meet the target. So this study was designed to evaluate the adequate frequency of injection, the level of drug, and among women, men and women from Brazil, South Africa, and Malawi. They include 200 people in 2 cohorts. In the first cohort, the participant received cabotegravir 800 every 3 months, and the follow-up of this cohort 4 was longer. And in the second cohort, the participant received 600 milligrams every 2 months. As seen in the table, the characteristics are similar among the 2 cohorts, and the rate of completion of the protocol in the cohort 1 and in the cohort 2 was higher than 80% in the cohort 1 and higher than 90% in the cohort 2 that received the injections as planned. The safety was acceptable. There were 90 grade 2 adverse events, 90%, but the difference between the placebo arm and the cabotegravir arm was similar. There was some adverse effect associated to cabotegravir, such as injection site reactions, that was 30%, and headache, that was 15%, much higher compared to the placebo. And there was a 46% patient that had a decrease in the creatinine clearance, but take care and understand that grade 2 clearance is a reduction of less than 90% milliliters per minute, which is non-significant in most of the patients. There was some other clinical significant events, such as the discontinuation. 7% of participants that received the cabotegravir discontinued by clinical adverse event, most of them not related to the drug, but also was 6 adverse events, including a transit weakness and post-ictal vertigo and renal failure, and one case of seroconversion that occurred 1 year later of stopping the drug. But the prevalence of adverse events and discontinuation was not statistically significant among the placebo arm and the active drug, taking into account that randomization was 3-to-1, and for this reason we see more effect in the active arm. Something that was real was the injection site reaction in 1/3 of the participants tend to be higher in the cohort 1 because they receive more active drug, even though it was every 3 months, but only in red was the severe cases with only 1 discontinuation in the cohort 2 due to the injection site reaction. In the cohort 2, where the administration of the drug was every 2 months, the frequency on inside of the reaction was a little lower, but still significant. Regarding to the pharmacokinetics, the cohort 1 confirmed the clear results showing that many participants had a level of drug below the expected range, and the variability with the women was significant. But the cohort 2, we can see here that most of the participants achieved an adequate pharmacokinetic, and there was very few difference between men and women, supporting the 600 milligram every 2 months with 1 month booster as a strategy for the next studies. In summary, 600 milligram is the dose preferred for male and female. The injection site reactions are frequent, but generally mild, with only 1 participant that discontinued for this reason. And now we are engaged in exploring the efficacy, because this trial was only for safety and PK, the efficacy of this combination to prevent HIV. And this will be done in the HPT1 and OA3 that will be carried out in Brazil, Peru, and Argentina, and many other countries. And we will explore those in a cohort of 4,500 participants from many sites of US, Africa, and Asia and Latin America. In the IAS also, we've got some information about perception and preference of PrEP. And I will share the PROUD qualitative study and the PrEP Netherlands study. In the PROUD, 40 patients were interviewed in deep in order to explore the perception. And as you see here, many participants say that after receiving PrEP, they could have a psychosocial benefit in terms of being more relaxed at the time to having sex, something for which we tend to subestimate among the patient or participant that ask about PrEP. There also more intimacy and more sense of control, and also better mental health outcomes in patients taking PrEP, which we should try to keep in mind when we see patients that are highly exposed to HIV. The PrEP cohort is a cohort in Amsterdam that a demonstration project that allows participants to choose between daily or intermittent PrEP, and allows also to switch between regimen or even to stop and continue follow-up. So this presentation was to try to explore what were the reasons for which the MCM choose or switch or stop the PrEP in the Amsterdam cohort. This was done collecting information through semi-structured interview with closed and open intents that were analyzed and presented in this session. There were 376 participants, 273 in the daily PrEP, most of them choosing daily PrEP, and 100 event-driven or intermittent PrEP. 40 patients in each arm chose to switch during the follow-up, and there were only 4% of the participants that stopped completely the PrEP use. When the participants are asked why they choose event-driven or daily PrEP, it's like the perceived HIV risk is the most important reason for which they select this option. In the event-driven PrEP, the participants tend to have the sexual more planned and with lower frequency of high risk than the participants that choose to take all-day PrEP, because they say that they need, I mean, for them it's easy to take daily because allows to not to think about or not to planning about having sex. Probably they have more sexual activity also. When we ask those that switched from intermittent PrEP to daily PrEP, again, the changes in the sexual behavior were the most frequent reason for which people that used to take intermittent PrEP changed to take every day, and also on the inverse in the patient that used to take every day and change to intermittent. The proportion of participants that choose to change the way they took PrEP because adverse event was more or less similar in both groups of participants. Some people in the intermittent had adverse event to 2 pills of tenofovir and changing to take only one every day, and those taking every day choose to change to intermittent PrEP because they have some effects. Problem with being adherent to daily medication was the most common reason for stop temporarily the PrEP, and the adverse event was the most common reason for stop completely the PrEP, although this was seen only in 8 from 18 patients that stopped it. This means less than 2% of the participants choose to stop the PrEP use. Others stopped it because they stopped to having a sexual risk. There was other studies presented exploring reasons for not using PrEP. These 2 studies, okay, see? And these 2 studies were in the US. Dr. Merkel showed a big survey, and Dr. Levy a mixed method research among 193 participants. The reason for not using PrEP in US is the cost, the lack of access, the lack of insurance, and the lack of awareness, with only 20% the perception of low risk. It's critical to see that 85% of people that required PrEP according to the guideline never use it or have been offered PrEP. So we have a lot to do in the US, but also in our country, where I am sure this kind of barrier are similar or higher. Regarding a sexual transmitted infection, we have the pleasure to see the presentation of Dr. Greenstein, where she reported in Brazil the prevalence of rectal chlamydia, rectal gonorrhea, and syphilis with an incidence and prevalence and incidence similar to developed country that is extremely high, like in Australia. These rates were stable along the 48 weeks, supporting that the participant continue being engaged in high sex relationship. Also, it's good to note that in most of Latin America, we don't have access to molecular diagnosis for chlamydia or gonorrhea that allows to identify this high percentage of infections. Another study from the US suggested that as more use of PrEP, as we see more use of PrEP, we can see more gonorrhea. But this was discussed because it's only a retrospective analysis from multiple sources, multiple big data, but and so it's not a clear relationship and was not consistent with chlamydia or syphilis. But which is clear and was shown by Lott is that the frequency of STI is also higher or high among HIV positive people recently identified. And the tendency is increasing since 2012. This means 2 or 3 years before the introduction of PrEP in France. And this is not only seen in France, the rate of syphilis and other sexual transmitted infections are increasing since 2007 in many countries among HIV positive and HIV negative people. In the UK, after the PROUD study, many MCM started to look for black market or alternative place where to find Truvada. And the health system was, I can say, was clever enough for allowing these people to come to the health system and receive counseling and make the required results and have counseling and how to continue taking the PrEP that they could take from internet and by through internet. Most of this was generic. 85% of these people of these 400 participants was taking Cipla generic, but the level were adequate, so these people was really interested and was taking well. Was very exposed people. 42% was participated in sex parties, and 36% had some STI diagnosis during the follow-up. So it was a high-risk population. Unfortunately, there was no any new HIV cases among those. So this kind of innovative program combining internet, generics, and health system in developing countries show to be effective in providing some responses to people that want to be prevented. Regarding chain sex, for those that doesn't know what this means, is the use of stimulants during sexual relationships in order to increase desire, the vigor, or duration of the relationship. And so it's very frequent. In Canada, for example, 46% is using cocaine, 37% speed, 1/3 ecstasy, 20% ketamine, heavy GHB, or crystal. But the critical issue here is that crystal can be a very dangerous drug for use, and we should counsel patients not to use it. So in this study, users of crystal was associated with 10 times more HIV infection than non-using crystal. It's important to ask the participant or the patient interested in taking PrEP about chemsex, as those are probably the more interested and also the more benefited by this program. And also we need to take care that in this chemsex is a high association with hepatitis C epidemics. Two last peers that will show you the importance of really roll out acute HIV infection among people that want to take PrEP, and this is the risk of resistance and the need of identify and move from PrEP to treatment to those patients that we identify as acute HIV infected when we started PrEP. The first poster is a poster from Pia Lux. We need to take into account that if the participant is having a seroconversion and we give them PrEP, we will have a 27% risk of HIV resistant strain due to the V therapy with Truvada to this HIV acute patient. But if we follow patients that we are sure that we were HIV negative because, for example, we perform viral load before starting PrEP, we can see that the risk of resistance is very, very low, less than 0.1% of the PrEP-treated cases. But here we are showing one case of seroconversion that in one patient that was taking very well the PrEP. He had adequate levels of tenofovir. He started the PrEP with a negative HIV serology. He has negative viral load as the researchers went back to the sample that they had and they tested, and he was not infected during when he commenced PrEP, but he enrolled in big chemsex parties, and probably he acquired one resistant HIV strain that had resistance to 3TC and has some mutation for protease inhibitors. So we need to take care and we need to advise participants that they should try to continue using condom and that we can reduce the risks of acquired HIV infection, but we cannot say that it's 100% effective because depending on the high risk, they can have some potential exposure to resistant virus that cannot be blocked by Truvada. The other poster is one participant that unfortunately started PrEP when he was HIV acute. However, the day that he started PrEP, the viral load was taken and was very fast turnover of the viral load. So he, after 2 days, the doctor had this information, called the patient, and put the patient in triplet therapy with darunavir and raltegravir, and he was very quickly suppressed and continued being suppressed after 2 years. And given that he has only 200 copies, he was a lot of interest in his doctor was to see if there was any reservoir or reduction in the reservoir in this patient. The patient was suppressed for 2 years, and practically most of the samples that were taken in rectum biopsia, plasmapheresis, bone marrow, inguinal biopsia, cerebral spinal fluid all were negative with the exception of one specific study in one humanized mouse model for identify HIV virus in blood injected in this mouse from this patient. After 2 years of treatment, the participant decided to stop PrEP because all the cultures were negative. He was 7 months without virus, with a good CD4 response or maintaining good CD4, but unfortunately after 7 months, the viral load increased again. So what this case tells us? This case tells that this participant could be 7 months being without viral rebound. This means that really the early initiation of treatment when the participant in PrEP was detected as having HIV allows to have a very small reservoir and allows to the participant to be without treatment during 7 months. And so if we could have some additional intervention for this kind of participants, we probably could be more close to the eradication or to the functional cure than if we focus in chronic infected patients. So it's important to continue having the testing the PrEP participant and to really very quickly to provide treatment if we identify that these patients are infected, because very early treatment is very good, although it's not enough. So finally, in order to close, the take-home message is that we continue having good evidence of long-term efficacy, as in the PROUD study, that the efficacy of the intermittent PrEP is very good, even in people that take very few or need to take very few times at the week this intermittent PrEP, because infrequent sexual intercourses, that the cabotegravir looks to be the best long-acting agent, and if the HPTN 083 shows efficacy, can be a good option for long-acting PrEP alternative. That the PrEP is important not only in order to reduce HIV infection, but also to improve the among HIV negative MCM, the quality of life and the healthy sexual relationship. But we also know that one size doesn't fit all, so maybe we need to think in program in try to provide not only continuous PrEP, but also consider for some participants the possibility to switch to intermittent dosing if the participant doesn't tolerate or doesn't have high risk activities. We are sure that need more implementation study to see what are the barriers and how to improve access, education, and retention, as we see that is a big gap among those that need PrEP and those that receive it. And we need to consider how to measure, how to identify, detect, and treat the STI in Latin America, where the resources for molecular testing is not available in most of the settings. We need to start to asking participants about the chemsec and counseling and providing advice to these participants in order to reduce risk. And we need to continue selecting very well our participants, be sure that they are HIV negative, and continue performing HIV testing during the follow-up in order to not treating acute HIV infection from PrEP. I want to say thank you very much for the invitation. Sorry for my English, and I hope in the future NEMUS webinar I can have a better English discussion. Thank you very much, and I will be very happy to share opinions or other information that you want to have.
Omar, thank you very much. Really, an excellent, very detailed summary of the conference, which was a very interesting conference. In fact, we were surprised to see how much focused on PrEP it was. No, and it's not necessarily a good thing. I'm not mentioning it as a value, but it was actually an objective observation. Definitely, it has taken several years, but finally, we all know this is a valuable technology in the context of combination HIV prevention, and apparently it's taking off, and it's starting to be the focus of many people's interest. Definitely, from that to actual implementation on a larger scale in countries, there's some distance, because PrEP is not a technology that is, I mean, at least in public health systems, it's not an easy to implement technology to the extent that it needs a number of tests, a number of, I mean, some level of organization, not to be put together. And of course, it's important to define a source of financing of PrEP when a country establishes it, particularly if it's to be provided by the public health system. In other cases, it's provided by public insurance. That's mostly the case in the US. So it's a different mechanism. So definitely when we talk about PrEP, we're talking also about implementation efforts. And that's the reason that demonstration studies are a good strategy to introduce PrEP in the context of HIV, of combination HIV prevention. Anyway, there are a few questions. Also, I have a couple. I wanted to start, Omar, with a question from Ricardo. He states that most critics of PrEP, at least in Latin America, mention the issue of resistance to antiretrovirals as a result of PrEP implementation, but he says apparently there's not much evidence of that. So what's your take about evidence of resistance to antiretrovirals from the conference? Do you think it's something that we need to continue to be so concerned about?
Thank you, Ricardo. I think that the question is more complex than that, and the response is more complex than that. I think it depends on who. I think that probably the doctors are more concerned about resistance. And it's like with the isoniazid. I did a revision of all the studies that were performed among PrEP. I am showing in the screen. Sorry, it's in Spanish because it was for another presentation. And we can see here that among 8,000 participants receiving PrEP, there were only 10 participants having resistance. This means that only 0.1% of the participants could emerge with resistance to Truvada, which is not, I mean, a death sentence, because you have other alternatives to be treated with if you are resistant to tenofovir now. But because most of the seroconversion occur in patients and participants that doesn't adhere very well. But I mean, we had these 10, but we avoided 150 infection in this trial. So it's not difficult to understand that the equation continue benefiting the intervention of taking PrEP. There are many different review, mathematical modeling, and probably it's true in 10 years, the resistance in the community to tenofovir because of PrEP can be between 1 and 8%. But this is very, very different from patients that started with acute HIV infection. And for this reason, as Carlos said before, it's complex to implement because we need to be really sure that the patient, the participant, is not in acute HIV infection, because the risk of resistance is 27%. I say this complex because in my country, at least, the critics is a strong critics from the community and not from the doctors. And actually here we had a visit from Nikos Dede from Europe. He's an activist. He was surprised to see that in Argentina the doctors were pro-PrEP and the potential beneficiaries were against PrEP. And this was mostly from HIV organization, and probably they are afraid to medicalize too much the epidemic, that the doctor will not invest time in asking for risk reduction practices, that the money for intervention for improved adherence and for improved condom distribution can be used for PrEP, and therefore the system will finally be doing more harm, and that some doctors can be manipulated by pharma industry or for pharma benefit in order to prescribe more PrEP. So it's in both sides. We need to take care of this comment, and we need to answer all these concerns before starting planning PrEP at the country level.
Yeah, absolutely. I think those are excellent points. In fact, one of the news at the Paris conference was released by the World Health Organization of the implementation guidelines for PrEP. So those were presented in a workshop, and I'm happy to say that at least in Latin American context, there will be no, actually, in both our webinars in English and Spanish, we'll hold sessions on the implementation guidelines. One will focus on providers, and a second one on programs, and a third one on communities. And as you say, in this region, Latin America and the Caribbean, important work is needed with communities. I think the issue of concerns about PrEP within communities is a whole topic that would deserve a long discussion. Probably there are good reasons in relation to, probably negative experiences with, certain kinds of research, the issue of, as you say, medicalizing the epidemic. And in fact, we have to recognize that it has been so important for the most affected communities to sort of change. It was so important to change behaviors and unite the community around the idea of prevention, and condom use came to symbolize that union, that sort of ethical standard. And so in a way, promoting or talking about combination prevention, particularly PrEP, implies a rupture, no? Implies some kind of deep change that many people fear. However, the first thing we have to recognize is that condom use is relatively, it's insufficient. In many cases, it's low, and it's even decreasing. And reasons for that are related to probably how people perceive pleasure or sort of natural interaction in sex. And we have to accept that. In many cases, we keep sort of preaching that people have to use condoms and have, but if we keep doing that and people, keep not using condoms, then the epidemic will continue. We have to recognize that in many parts of the world, HIV incidence is actually not decreasing. In many cases, it has remained steady, and in the past few years, it has actually increased. So that's a challenge, and for that reason, we need to start talking about combination HIV prevention with, a good place for treatment as a prevention strategy, and viral suppression and all that, which in many places is not done sufficiently. We need to use PrEP as much as it's needed, and strategies of people to use condoms in recognize that people throw sorts, and finally use PrEP where needed and I mean, as in the best ways possible. Anyway, a couple of things. Definitely, adherence is very important, and it's probably something that needs to be explored with the communities, looking at how they respond. It's interesting.
Well, but actually, that
Yeah.
adherence, I mean, it's more forgettable than HIV treatment. I mean, if we can ensure that at least the participant take 4 than the 7 pills each week, they can be really protected. So it's not a big issue if we can do that, you know.
Yeah.
And
Yeah.
regarding the cost issue and who should pay, is I will put in this also this is in pesos in Argentina, in Spanish, sorry. The number necessary to treat in order to prevent 1 case of HIV is 13. 13 for the according to PrEP, or 18 according to the hypergay study. So it's less than 20. But you know how many women you need to treat with ivandronato and calcium and vitamin D in order to avoid a fracture? 100. So we need to treat 26 participants with statins to avoid an infarction. So nobody reject those preventive activities based on the number to treat, because everybody say that it's good. I don't know why PrEP, that is more involved with the sexual activity, the people are more negative in order to provide. And the cost, regarding the cost, as we have in Argentina generics, the cost of the PrEP is lower than rosuvastatin, or is lower or similar to calcium and ivandronato. So I think the discussion is also involved for the prejudice about preventing something that can be prevented for not having sex. I mean, you can prevent infarction, myocardial infarction, for not smoking and doing exercise and diet, and nobody will punish patient for not doing that. But the discussion in MCM is why I will pay for somebody that is having sex without condom. And I think this is kind of ethical issue that we need to, as a society, to discuss.
Yes, absolutely. And you know, we will have to end soon, but there are a couple of issues that, I mean, where you could perhaps mention briefly what you think. One is, I mean, definitely STIs again, the magnitude and the response, because it for many people it's a key issue, and the second thing is, I mean, the difference with women, because many regimes, I mean, there's something called forgiveness that is about, I mean, the ability of PrEP use to, even if it's not perfect, if adherence is less than ideal, to actually still protect. But with women, it's not the same, because I mean, for vaginal protection, it's things don't work so easily. So maybe a couple of quick things about that, those points, Omar, please.
Yes, absolutely. I think the intermittent dosing for women is not working, but also we are discussing here in Argentina what women is really the best eligible people for PrEP, because as you know, the incidence rate is extremely high among transgender women and is high among MCM, but among women is very, very low. And if we talk about sexual worker, for example, women sexual worker now in Argentina has a very low incidence rate. So probably this group of people will not benefit much of PrEP. Probably in an individualized discussion, women that have a partner that is HIV positive and the partner cannot take treatment or just starting treatment, and is not suppressed, and she cannot negotiate to use condom, probably will be a good client for PrEP, but this is not there are very less cases compared with MCM and transgender.
STIs.
And regarding STI, is a problem here. I mean, if you have a population with 30% of STI and no new infection, you are doing a great job. At least, I mean, you can cure syphilis, you can cure gonorrhea, you can cure chlamydia, but you cannot cure HIV. So for me, it's hopefully those patients in the PROUD and the IMPREGATE were receiving PrEP. The problem here is that we don't have how to detect. So what we will do, we will treat. We know that the chlamydia and gonorrhea is 10% in this population. We will treat this population empirically. Another issue in STI is if you do a prevalence sample in your population of MCM population, it's much lower than among MCM people involved in PrEP. And I don't know, it's a question for you that we're doing more trials than we did in MCM, but it's probably the PrEP participants are self-selected and are more involved in sexual practice than the general MCM community. I don't know, what do you see?
Yes, no, definitely in many places where PrEP has become, I mean, at least the two countries where the most important studies in the recent period have been conducted in England and France, definitely the willingness of MSM at high risk to self-select and participate is obvious, and it's a part of the risk. It explains the success of results of those studies. Anyway, I think we have to stop here, and I mean, before I end, just would like to mention that this session has been recorded. We'll upload it to our website and YouTube channel. We'll also share the link, and I mean, tomorrow we'll have a session in Spanish. I apologize because at the beginning, I mean, there's a new setup of GoToMeeting, and I'm not familiar with the settings, so I started talking with my mic off. So I just said I welcome people, and I mentioned that this is a new phase where we are part of IMPREP, the demonstration study of PrEP in Brazil, Mexico, and Peru. So we are, I mean, besides doing the Peru component, we're also including NEMUS within the project as part of our knowledge sharing effort. So we'll present on that study very soon for people to know about it. I just announced this here. And in any event, we will be having more webinars mostly in English and Spanish. We'll usually do both languages, and actually Spanish, Portuguese in some cases. So stay tuned, and I want again to thank Omar very much for his collaboration today and tomorrow. Thank you, Omar.
Thank you very much. Thank you for the invitation. Bye-bye. See you tomorrow.
Okay, and thank you all, and we'll keep in touch. Thank you. Bye-bye.